Good day, my dears. The topic of today's lecture is specific inflammatory diseases in the area of head, neck, and jaws. We'll talk about actinomycosis, tuberculosis, syphilis, and manifestations of HIV infection in the maxillofacial region. And let's start from actinomycosis. Actinomycosis is an infrequent invasive bacterial disease that has been recognized for over a century. Actinomyces are filamentous gram-positive bacilli mainly belonging to a human commensal flora of oropharynx, gastrointestinal tract, and urogenital tract. To date, multiple different clinical features of actinomycosis have been described as various anatomical sites such as a face, bone, joints, respiratory tract, genitourinary tract, digestive tract, central nervous systems, skin, and soft tissue structures. All these structures can be affected by actinomyces. Of note, in any site, actinomycosis frequently mimics malignancy, tuberculosis, or nocardiosis as it species continuously and progressively and often forms a cold abscess. More than 30 species of actinomyces have been described, and for example, actinomyces israeli is the most prevalent species, is related in a human infection, and is found in the most clinical forms of actinomycosis in the maxillofacial area, in the neck, and other areas or regions of the body. The bacteriological identification of actinomyces from a sterile site confirms the diagnosis of actinomyces. However, isolation and identification of these causative bacteria occur in only minority cases. The failure rate of culture is high because of previous antibiotic therapy. Inhibition of actinomyces grows by concomitant and contaminant microorganisms, inadequate culture conditions, or inadequate short-term incubation. Because of the microaerophilic or strict anaerobic character of actinomyces, strict anaerobic processing, what does it mean? Rapid transport to the laboratory and transport in an anaerobic transport medium, and anaerobic growth conditions should be used for primary isolation. The most appropriate clinical specimens are tissues from surgical biopsy or pus. Swabs must be avoided. Finally, clinicians should indicate suspicion for actinomycosis to the microbiologists to ensure that prolonged culture on appropriate media and in an appropriate atmosphere is performed. Moreover, the identification of actinomyces in mucosa where the bacteria are normal inhabitants is of a little significance in absence of sulfur granules or a typical clinical syndrome, highlighting in importance of microbiological investigations in combination with histologic analysis. And in this slide, I showed you sulfur granules, and you can see them in a slide or in a picture, and actinomyces as filamentous bacteria, and you can see them in picture B. And the next slide shows us growth of actinomyces. And that should be understandable that the growth of actinomyces is slow. It appears within at least 5 days and may take up to 15 or even 20 days. Thus, incubation of at least 10 days is required before conclusion of negative culture. Most actinomyces are facultative anaerobes, but some relevant species, such as, for example, Actinomyces meyeri, are strictly anaerobic, so cultures must be incubated in anaerobic atmosphere, as I said previously, and they can be cultured on chocolate blood agar media at 37 degrees by Celsius. Actinomyces can be initially suspected by colony morphology and biochemical profiling. For example, Actinomyces rarely forms a molar tooth, and you can see this picture or culturing in the agar, blood agar. It looks like molar tooth or even wisdom tooth, which is inside the jaw. And this molar tooth colony on agar, and they grow as clumps within brows, whereas Actinomyces odontolyticus forms rust brown or red colored colonies. Gram staining of the pus and pathology of infected tissues is of great interest for the diagnosis of actinomycosis, as it is usually more sensitive than a culture which remains sterile in more than 50% of cases. Once actinomyces have invaded tissues, they develop a chronic granulomatous infection characterized by formation of tiny clumps called sulfur granules because of their yellow color. These formations of 0.1 to 1 millimeter in diameter, composed of an internal tangle of the micellar fragments and rosette of peripheral clumps, are stabilized by a protein polysaccharide complex, which is supported or supposed to provide a resistance mechanism to host defense by inhibiting phagocytosis. Drug resistance is not considered a problem in actinomycosis. Indeed, actinomyces are usually extremely susceptible to beta-lactams and especially penicillin G or amoxicillin. As a consequence, penicillin G or amoxicillin are considered drugs of choice for treatment of actinomycosis. Third generation cephalosporins are less frequently used, even if they are considered to be active on Actinomyces israeli. However, it is important to note that the species are resistant to ceftriaxone, and they are Actinomyces europaeus and Actinomyces gravenidzi. Piperacillin, tazobactam, imipinem, meropenem are considered to be active, but the use of these broad-spectrum antibiotics should be limited to avoid squishing of resistant flora. Oxacillin, clofacillin, and cefalixin, a third-generation cephalosporin, are not considered to be active. Metronidazole and aminoglycosides have no in vitro activity against actinomyces. Of fluorohyalurones, ciprofloxacin and moxifloxacin are usually considered to be inactive, but data are limited and controversial. Doxycycline is considered to have a poor activity on actinomyces, but clinical success has been reported with this drug, and macrolides and clindamycin have been used successfully as alternatives. As actinomyces do not produce beta-lactamases, it is not useful to combine amoxicillin with beta-lactam inhibitors such as clavulanic acid, except if co-pathologies or pathogens such as enterobacteriaceae are involved in the disease. In this slide, you can see manifestation of clinical features and symptoms of cervicofacial actinomycosis. And what is it? Cervicofacial actinomycosis is the most frequent clinical form of actinomycosis and lumpy jaw syndrome, which is associated with odontogenic infection in the most common clinical manifestation, representing approximately 60% of all reported cases. Actinomyces could also be responsible for maxillary osteomyelitis in patients with odontogenic maxillary sinus sinusitis. And in a little bit later, I'll show you pictures, X-rays of patients with odontogenic maxillary actinomycosis and osteomyelitis, which is caused by actinomyces. Actinomyces are commensal of the human oropharynx and are particularly prevalent within gingival crevice, tonsillar crypts, periodontal pockets, and dental plaques, as well as on the carious teeth. Consequently, actinomycosis is mainly considered an endogenous infection that is triggered by a mucosal lesion. Cervical-facial actinomycosis can lead to distant organ dissemination, including brain, lungs, digestive tract. Cervical-facial actinomycosis is a relatively rare condition worldwide with no predilection for age, race, season, or occupation. Physiopathological pathways of cervical-facial actinomycosis explain that predisposing conditions include poor oral hygiene, as dental caries, gingivitis, infection of erupting secondary teeth, and oral mucosal trauma, especially dental extraction or maybe gingival trauma or local tissue damage caused by neoplastic condition or irradiation, cervicofacial surgery. Other predisposing factors include male sex, diabetes mellitus, immunosuppression, alcoholism, and malnutrition. And of course, in most cases, these are only theoretical predisposing factors because, as I said earlier, there is no predilection of age, race, seasons, or occupations. Cervicofacial actinomycosis usually involves tissue surrounding the upper or maxillary expansion of the jaw, all over mandible, including the mandible itself in approximately 50% of cases, cheek 15%, and chin the same 15% of cases. Submaxillary ramus and angle, nearly 10% of cases. More rarely, the mandibular joint could be involved. Typically, the disease presents as a slowly progressive, painless, indurated mass involving into multiple abscesses with draining sinus tracts on the skin surface, on oral mucosa, sometimes expressed in a typical thick yellow exudate with characteristic sulfur granules. At advanced stages, pain and trismus can occur linked with the mastication muscles infiltration. Acute suppurative forms with rapid abscess formations are less common and are usually fibral and painful. Regional adenopathy is rare. Bone involvement is observed in approximately 10% of cases. And in this slide, you can see actinomycosis or actinomyces or osteomyelitis, which is caused by actinomyces. And on the upper part of the slide, you can see fistulas formations due to this osteomyelitis. Fistulas are not rare even if this osteomyelitis is caused by other types of bacteria, but in actinomyces are found as well. Although most cases of odontogenic origin and concern of perimandibular regions, many other locations of primary infection have been described, including the tongue, sinuses, middle ear, larynx, thyroid glands, and lacrimal pathways. Imaging findings are usually non-contributory to the positive diagnosis. Dental panoramic radiograph is mandatory to assess apical abscess, which will require dental avulsions. CT scan and MRI may also or may show a non-specific involvement of skin and soft tissues, but are useful to assess bone involvement. In case of chronic osteomyelitis, osteolysis is common with a forcible periosteal reaction and intralesions gases. And in this slide, once more, we can see osteomyelitis or sequestrum, which is inside healthy bone. And in the same time, on the skin, we can see fistulas formations. And that is normal physiological reaction of the organism. Of course, in order to put final diagnosis, we have to do culturing, and we have to be sure that this pus does not contain actinomyces. This patient on this slide is a 77 years old woman with past history of breast cancer. She was admitted 7 years after radiotherapy for left mandibular metastasis with left mandibular pain, buccal-sided bone exposure, and sinus tracts. The patient had been receiving long-term trastuzumab therapy with bisphosphonates. As the patient was suspected to have chronic osteomyelitis with actinomycosis, left total hemimandibulectomy was performed. Pathology revealed suppurative osteomyelitis. Null sample was sent for the microbiological diagnosis. And let's move on to other case. In this slide, you can see X-ray. This X-ray is of a 43 years old woman presented with lumpy jawbone or lumpy jaw syndrome following root canal treatment of two right mandibular molar teeth, 45th and 46. Those 46 was extracted, followed by those 45. 2 months later, a mandibular actinomycosis due to the actinomyces Naslandi was diagnosed after surgical debridement and decortication. Prolonged high doses of amoxicillin, 9 gram per day intravenously over 6 weeks, followed by 6 gram day orally, was prescribed. 1 year later, despite the continuation of the antimicrobial therapy, the patient worsened with extraction of the osteomyelitis to the gonial angle and to the ramus, and we can see it in this picture. So we can see that those were extracted, and the angle and ramus were normal. We can see only in this area pathology. So, and in 1 year, there was a recurrence of symptoms, and new surgery was performed 3 weeks after discontinuation of amoxicillin therapy. And actinomyces naslandi suspectable to penicillin G was again found in cultures from perioperative samples. Amoxicillin was prescribed for 14 months, and after 1 year of following up after amoxicillin discontinuation, no relapse was observed. Cutaneous actinomycosis. Primary skin and soft tissue actinomycosis is poorly described, and skin disruption may facilitate invasion of actinomyces. Most patients have progressive skin and soft tissue inflammation, which can become an abscess or cold mass or nodular lesion with fistulas that need to be differentiated from chronic inflammatory skin disease, cutaneous mycobacterial infection, and sporotrichosis. In patients with primary skin and soft tissue actinomycosis, abscess has to be drained and prolonged antimicrobial therapy is required to achieve cure. So in this slide you can see pictures in which we can see it's so-called cold abscess because we can see hyperemia. We can see some discoloration. The skin above the abscess is more dark than adjacent tissues, adjacent skin, but it is painful as abscess. But there is no any movement inside abscess. I mean, enlargement of edema, enlargement of hyperemia or pain. It looks like cold without any local fever in this area. So, but that doesn't mean that it shouldn't be drained. The main treatment for abscess, that is drainage, and actinomycosis abscess should be drained as all classical surgical steps for abscess treatment. Diagnosis can be difficult, and especially making a distinction between neoplastic conditions, malignant hemopathy, and other cervicofascial infections such as nocardiosis or mycobacterial infection. Non-specific and mild biological inflammatory syndrome can be found. The gold standard for the diagnosing cervicofascial actinomycosis is histological examination and bacterial culture of the abscess or of suspected bone if osteomyelitis is suspected. Microbiological cultures of bone samples have to be incubated not less than 2 weeks, and after 10 days, even after 10 days, we can say that the pus is sterile. In patients with odontogenic cervicofascial actinomycosis, prescription of oral antibiotics or oral antimicrobials is common before surgery, leading frequently to false negative results of the culture. Surgical management can be required for drainage of voluminous abscess, marsupialization of chronic sinus tracts, extraction of recalcitrant fibrotic lesions, and debridement of necrosis or necrotic bone tissue in case of osteomyelitis. Treatment of dental caries and periapical or apical abscess is essential, often necessitating dental evulsions. No randomized controlled trials have evaluated antibiotic regimens for cervicofascial actinomycosis. Most isolates are susceptible to beta-lactams, and I won't repeat different types of antibiotics and which one is susceptible or non-susceptible, and you can see it on a slide. The same antibiotic main management of antibiotic treatment includes penicillin G, beta-lactams, and cephalosporin. If patient is allergic to penicillin, we can prescribe clindamycin or macrolides, such as erythromycin or clarithromycin or azithromycin, and doxycycline. So for actinomycosis, that is all. I showed you the most usual or common types of actinomycosis. That doesn't mean that only cutaneous form or actinomycosis as osteomyelitis can be found in patients, but it can be, for example, actinomycosis or actinomycotic maxillary sinusitis. It can be arthritis, which is caused by actinomyces, but they are very rare cases, and no need to talk about it. The next part of our lecture is tuberculosis. What is tuberculosis? That is specific infection or specific inflammation caused by Mycobacterium tuberculosis or in contraction MBT. Second only to HIV or AIDS as the greatest killer worldwide, especially in developing countries where its prevalence is very high. The probable reasons for this are poverty, overcrowded shelters, lacking public health efforts to control tuberculosis or HIV infection epidemic, and development of multi-drug resistant bacteria. Orofacial tuberculosis is uncommon from a form of extrapulmonary tuberculosis and is not specific in its clinical presentation. It can be misdiagnosed, especially when oral lesions are present before systemic symptoms become apparent. Doctors, especially attending dentists, who generally is the first among clinicians to come across such a pathological entity, should be aware of the orofacial lesions of tuberculosis and consider them in the differential diagnosis of suspicious oral lesions to ensure early diagnosis of tuberculosis and its treatment. Orofacial tuberculosis Oral tuberculosis can be primary or secondary. Primary form is rare and more commonly found in children and adolescents. In contrast, the secondary form is more common and is usually seen in middle-aged and elderly patients. Orofacial tuberculosis can involve any site of oral cavity and the associated structures such as the tongue, palate, lips, oral mucosa, jaw, bones, sinus, cyst, temporomandibular joint. Recently, Andrade and other authors proposed a classification of orofacial tuberculosis based on the site of involvement, and you can see this classification on the slide. Type 1 lumpy jaw, mandible, or maxilla is involved, and extraoral swelling is present without intraoral or extraoral draining sinuses. Second time, non-healing extraction sockets with or without intraoral or extraoral draining sinuses or sinus. Third type, intraoral or extraoral draining sinuses in the orofacial region and an osteomyelitic bony lesion. Fourth type, lymph nodes tuberculosis or tuberculosis lymphadenitis of the head, face, neck region without any features of type first, second, or fifth. And fifth type, lesions of other sites in and around the oral cavity, for example, maxillary, antrum, salivary glands, gingiva, orofacial muscles, tongue, and others. And the next slide, various manifestations of orofacial tuberculosis. Maybe it's not seen well, but you can zoom this picture and read it by yourself. You can stop this video and read manifestations according to the different types of different sites of tuberculosis infection. And I want to see the next slide, tuberculosis ulcers and gingivitis. Many present a single or multiple superficial or deep, painful or painless ulcers with an irregular border which tends to increase slowly in size. They usually develop as a small tubercle which then softens to form a shallow or void ulcer which undermine the margins and is lined with pale granulation tissue. Tiny single or multiple nodules called sentinel tubercles may be seen surrounding the ulcer. Tongue is the most common affected. However, lesions also occur on the floor of the mouth, gingiva, palate, and lips. The differential diagnosis of tuberculosis ulcer or the oral cavity includes traumatic ulcers, syphilitic ulcers, aphthous ulcers, and various canceromas like squamous cell carcinoma or lymphoma, for example. And you can see that it looks like specific inflammation, not common inflammation. And as I said, it can be deep or superficial. It can be painful or painless. So a lot of different manifestations. But from the first look at this ulcer, you can understand that something wrong with this patient, that is not simple ulcer, and tuberculosis or syphilis or actinomycosis may be suspected. And of course, in most cases, that is tuberculosis ulcer or syphilitic ulcers. Tuberculosis gingivitis. This condition or this disease may appear as nodular or papillary proliferation of gingival tissues, which is diffuse and hyperemic. There may be absence of any clinical attachment loss, alveolar bone loss, or significant cervical lymphadenopathy. Such diffuse gingival enlargements fail to respond to initial usual therapy consisting of supragingival debridement. Sometimes tuberculous gingivitis can be seen simultaneously with marginal periodontitis and enlarged cervical lymph nodes, or may present as periodontal loss of tooth support, leading to loose teeth and gingival enlargement. A biopsy of the lesion is mandatory for arriving at the diagnosis of tuberculosis. The next one is tuberculous dental periapical granuloma. Tuberculous involvement of the periapical tissue has often been reported. Three routes can be perceived to be entry portals for the tubercle bacillus to come or to become implanted in the periapical tissues. The first is the invasion of the dental pulp through a deep carious lesion by the acid-fast bacilli in the saliva. Should the pulp degenerate and break down, a tuberculous periapical infection might result. A second route is hematogenous, and third is deep periodontal pocket. Patients not responding to the usual periodontal treatments may be harboring tuberculosis infection in the paradental tissues even though its presence is not evident. The lesions are usually painless and sometimes involve a considerable amount of bone by relatively rapid extension. So, and by visual examination on this slide, you can see that no differences on X-ray or by X-ray can be found, and that is impossible to diagnose tuberculous dental periapical granuloma from simple dental periapical granuloma. So, culturing is obvious or mandatory to put a diagnosis and, of course, to prescribe susceptible antibiotics in order to improve or treat this patient. The next slide is according tuberculosis involvement of extraction sockets or teeth. Healing of the tooth extraction sockets is delayed and the socket gets or alveolar gets filled with tuberculous granulation tissue consisting of many pink to red elevations. So, the same. For example, we have a patient with diabetes mellitus, which is unfortunately widespread in our days more recently. And the second or other patient with tuberculosis, which is or orofacial tuberculosis, and which can impact or influence on the process of healing after tooth extraction. Of course, that will be quite different, quite difficult to differentiate between them. The same culturing is obvious. And let's look at the next slide and move on to the tuberculous osteomyelitis. So the main word on this diagnosis is of course osteomyelitis. And the next, maybe I am wrong when I said that the main word, but the disease is osteomyelitis, and the course is Mycobacterium. Mycobacterium. So the manifestations will be like osteomyelitis, but treatment should be antibiotic treatment, and prescription should be different. Tuberculosis osteomyelitis is rare and constitutes less than 2% of skeletal tuberculosis. Jaw involvement is even rarer. The mandibular involvement is more frequent than maxilla, and alveolar and angle region have greater affinity. Tuberculosis osteomyelitis commonly affects the adults, however, in some cases, children are also affected. The spread of infection may be by direct transfer from infected sputum through the extraction socket or mucosal opening associated with an erupting tooth, or by regional extension of soft tissue lesions to underlying bone, or by hematogenous spread. So the routes of spread are quite similar to other type of odontogenic infection. Tuberculosis of the jaw causes slow necrosis of the bone and formation of the subperiosteal abscess or lumpy jaw, appearing as a painless soft swelling. This subperiosteal abscess may burst, resulting in a single or multiple sinuses, intraorally or extraorally, and you can see the sinuses which are intraorally on this slide, and here we can see extraoral sinuses. So only by the picture that is impossible to understand if this osteomyelitis is caused by Mycobacterium or by Actinomyces or by Staphylococcus or Streptococcus. Pathological fracture of the mandible or sequestration may also occur. Diagnosis of tuberculosis osteomyelitis is a significant challenge as the smears for acid-fast bacilli usually do not yield positive results. Polymerase chain reaction or nuclear amplification assays may be helpful in obtaining an earlier diagnosis. However, a negative result doesn't rule out tuberculosis. In the early stages, when plain rentgenographs or radiographs appear normal, MRI or CT may have to localize lesions. The radiographic picture of tuberculosis osteomyelitis usually presents as a blurring of the bone details leading to diffuse radiolucence picture and cortical plate erosion. It can also present as a mixed radiolucence, appearance of worm-eaten appearance of the bone, and I prepared for you a slide of bony lesions which with fistula formation through which small sequestra are excluded. The findings are similar to that of the destructive disease if the periodontal tissues get involved. More advanced lesion may appear as osteoporosis, bone lysis, sclerosis, and periostitis that mimic chronic pyogenic osteomyelitis, and it's often difficult to differentiate the two conditions. Joint involvement may be present, but unlike pyogenic osteomyelitis, articular margins and cartilage space are spread. Solitary lytic lesions can also appear sometimes, which can mimic neoplasia. Biopsy is mandatory for diagnosis, and anti-tuberculosis drugs along with surgical debridement is required, and they are the main mode of treatment. So in this CT we can see mouth eaten symptom of tuberculosis, of osteomyelitis, and in this slide we can see a sequestrum. So all features of chronic osteomyelitis, but the reason of this osteomyelitis is tuberculosis. The next slide shows us maxillary sinusitis, which is tuberculosis the same, and you can see types of assessment: CT and extraoral view or external view. Tuberculosis of the maxillary sinus is usually a disease of adults and remains an underdiagnosed entity. It is usually secondary to pulmonary or extrapulmonary tuberculosis resulting from the bloodstream or by direct extension. Primary sinonasal tuberculosis is rare, probably due to the bactericidal secretion, ciliary movement, and mechanical filtrating by vibrissae of the nose and sinuses. Most commonly, it presents as a nasal discharge, stiffness of the nose, crust formation, and sometimes with epistaxis. It can also present as fluctuant swelling, polyspathy tumor, and may resemble a malignant lesion. And I prepared for you this slide which shows us types of sinonasal tuberculosis. And you can see that there are three types and they have been described as first, second, and third. The first one is mucosal involvement leading to formation of polyps with minimal pus discharge. This type is more common. The second type is bony involvement and fistula formation with abundant discharge of acid-fast bacilli. This type can lead to midfacial defect. The third type, hypoplastic type, that is formation of granuloma, and this granuloma can mimic to malignancy. If not treated early, this granuloma can lead to complications like brain abscess and deterioration of vision. Antral leverage examination of acid-fast bacilli and culture for Mycobacterium tuberculosis can facilitate early diagnosis. The diagnosis of tuberculosis sinusitis is usually based on the absence of response to usual antibiotics, the presence of caseous granulomatosis, inflammatory lesions, and by bacteriological culture of polymerase chain reaction assay. Sinus surgery may be required for sinus drainage and specimen collection. CT or MRI can be helpful to figure out the extent of disease. Appearance of calcification in sinuses on CT scans can be indicative of sinonasal tuberculosis, and the imaging findings are mostly non-specific. Anti-tuberculosis medication and surgical debridement is the mainstay of the treatment. Tuberculosis. The most common salivary gland involved in a primary tuberculosis are parotid glands, whereas in systemic tuberculosis, mandibular glands are most commonly involved. There are two clinical forms of tuberculous parotitis, and the first is the localized form, which is common and involves intraglandular or periglandular lymph nodes, while the other diffuse parenchymatous form is very rare and is considered to be an acute pathology involving whole the gland. It may be secondary to the nodal infection, and initially Mycobacterium manifests in nodes of the periauricular area. It presents as a slow-growing, non-tender localized swelling in front and below the ear. The pain, abscess, fistula, and facial nerve involvement are the later features. The constitutional symptoms of tuberculosis, like chronic cough, fever, weight loss, may be present but are rare. The diagnosis of tubercular parotitis is very difficult because of the absence of symptoms and may often be misdiagnosed as benign parotid tumor. A detailed history, examination, and fine needle aspiration have been advocated for the diagnosis of the tubercular parotitis. The Zale-Nielsen staining and culture for the Mycobacterium is usually found negative. If the patient is not already known to have tuberculosis or other mycobacteriosis, the diagnosis is made by microscopy after excision of the gland. Polymerase chain reaction or PCR should always be considered before surgical intervention to enable differential diagnosis of the salivary gland tumor. And in this slide, you can see tubercular parotitis, and you can see that there is no any specific symptom uh, and submandibular gland involvement, and this is lymph node, which is a reactant or like a response of the organism of inflammation. We do not know only by photo or by picture if in this lymph node tubercular lymphadenitis, but it looks like because there is a tubercular sialadenitis. The next, of course, will be lymphadenitis. Tuberculous lymphadenitis is the cervical region, also known as scrofula. Scrofula is the most common site of extrapulmonary tuberculosis and accounts up to 5% of cervical lymphadenopathy. It often affects children and young adults in age range of 15 to 40 years and shows female predilection. It can present as a single bilateral neck mass affecting deep lymph nodes and may be associated with supraclavicular and axillary node involvement. Patients present with slowly enlarging asymmetrical lymph nodes in the neck, which is persistent. The mass is referred to as a cold abscess due to lack of local color or warmth, and the overlying skin presents as a violet color. Other symptoms of disease, such as a fever, chills, malaise, and weight loss, are present in about 43% of patients. As the lesion progresses, skin becomes adherent to the mass and may rupture, forming a sinus and an open of the wound. And on this slide, I try to find for you a picture with sinus which is forming due to the tuberculous lymphadenitis. And of course, that means that lymph node capsule is ruptured and it can cause tuberculous adenophlegmon. Fine needle aspiration cytology and direct microscopic screening for acid-fast bacilli are recommended for the routine diagnosis of the tuberculous lymphadenopathy, along with the culture that remains the gold standard for diagnosis. Diagnosis often requires biopsy and Therapy includes various types of anti-tuberculose chemotherapy, surgical excision, or a combination of surgery and chemotherapy. The next form of orophyseal tuberculosis, that is lupus vulgaris. Lupus vulgaris is the most common form of cutaneous tuberculosis found in individuals with moderate immunity and high degree of tuberculin sensitivity. It is caused by Mycobacterium tuberculosis and can involve the skin by hematogenous or lymphatic route. 80% of the lesions are of the head and neck, and the most often on the face, around the nose, eyelids, lips, cheeks, and ears. Females are affected 2 to 3 times more often than males. Lupus vulgaris skin lesions are often 5 types, and they are plaque, ulcerative or mutilating, vegetating, tumor-like, and papulonodular. The plaque form is most common form of lupus vulgaris, accounting 32% of cases, whereas ulcerative form is the most destructive and deforming of all lesions. A single or several unilateral reddish-brown papules first appearing on the face, neck, or arms, and then coalescing into erythematous plaque. The surface of the papules exfoliates and the center scars. Papules recur of the scarred areas gradually and repeatedly enlarging and coalescing. This leads to the formation of the large, firm, elevated plaques. At the periphery are small reddish yellow or brown nodules. The characteristic lesions is reddish-brown plaque composed of nodules which show an apple jelly color when pressed with a glass spatula or diascopy. The lesions may ultimately develop into disfiguring skin ulcers if left untreated. In long-standing scarred lesions, squamous cell carcinoma can develop. Lupus vulgaris is diagnosed by clinical features, pathology, and strong positive in tuberculin skin test. Identification of Mycobacterium tuberculosis is made by PCR or culture. The disease treatment consists of systemic anti-tuberculose drugs. And on this slide you can see lupus vulgaris in plaque form in the upper picture and ulcerative form in the lower picture. Treatment. The treatment of orophyseal tuberculosis is the same as standard antimycobacterial treatment regimens used for treating pulmonary tuberculosis. The 5 basic of first-line antibiotics that form the core of tuberculosis treatments are isoniazid, rifampicin, parazinamide, ethambutol, and streptomycin. Linezolid, and diacetazone. For tuberculosis, that is all. And let's move on. Manifestations of syphilis. Syphilis is an infection disease caused by spearhead called Trypanemma pallidum, which has a tropism for several organs and tissues in the body, causing complex clinical manifestations. The precise origin of syphilis is unknown, although two main theories prevail. One is that the disease was endemic to America and brought to Europe after Columbus discovered in 1492. The other The other one suggests that syphilis was endemic to Central Africa and reached Europe before the voyage of Columbus. Recently, a DNA-related strain of Treponema pallidum, which causes a disease with mixed features of syphilis and yours, have been found in an isolated tribe living in Guyana. It has been suggested that this organism may represent the progenitor form which Treponema pallidum has evolved thousands of years ago. Treponema pallidum has a slender, coiled morphology, and when examined by dark field microscopy, it moves with the drifting rotary motions or corkscrew. Treponema pallidum cannot survive outside its only known natural host, humans, because it has limited metabolic capacities in order to synthesize its own bionutrients. Syphilis spearheads, like other virulent treponems, cannot be cultivated in vitro. The primary mode of syphilis transmission is sexual contact. After Treponema pallidum penetrates through the genital mucosa or abraded skin, it enters the lymphatic and bloodstream and disseminates to various organs, including CNS. The incubation time is directly proportional to the size of the inner column and may vary from 3 to 90 days. In about 10 to 20% of cases, the primary lesion is intrarectal, perianal, or oral. Different with other sexual transmission diseases, for example, HIV infection or virus, Treponema pallidum is easily transmissible by oral sex, kissing, and close contact with an infection lesions. An important common mode of transmission is in utero transmission. In addition, transmission can occur at delivery if the newborn comes in contact with a contagious lesion. Blood transmission can be another mode of transmission, although today quite rare. Healthcare workers and laboratory personnel can acquire the infection if their unprotected hands come in contact with the spearheads. And let's see the next slide. Clinical manifestations of the syphilis. Syphilis evolves through a series of four overlapping stages, commonly known as primary syphilis, secondary syphilis, latent syphilis, and tertiary syphilis. Each stage has distinct clinical characteristics and degree of infectivity. Potential and prenatal transmission may induce distinct clinical manifestations. And let's see on this slide. The primary stage of infection is known as a syphilis chancre, which occurs at the site of inoculation. Chancre starts as a papule that may evolve into the indurated, painless, non-purulent ulcer with clean base. The size varies from 0.3 to 3 cm and borders appear marginated. Chancre can be single or multiple and usually regress without treatment after 2 to 8 weeks. The majority of extragenital chancres occur in the mouth till 75% of cases, although they can be observed in any body parts, including hands of healthcare workers. Regional lymphadenopathy occurs in up to 80% of cases, about 7 to 10 days after the development of the genital chancre. On this slide, you can see erosion, and that is not even erosion, that is an ulcer. That is a primary syphilis, syphilitic chancre. in the oral cavity. And of course, that is understandable that it was or the way of transmission is unprotected oral sex. The secondary stage um, develops after 2 to 12 weeks after the first contact with the organism. This stage is the result of hematogenous dissemination in the organism and the microorganism um, in very high number colonize several organs, giving constitutional and mucocutaneous manifestations. A rash of varying extensions is the most common presenting symptom. The rash typically does not cause prurites and develops as a symmetrical 3 to 10 millimeters pink or red macules, which can progress to papular or pustular form. If untreated, the rash resolves over several weeks without complication, the same as primary syphilis or syphilitic chancre. And before I'll show the rash, let's look at this slide, and you can see the uh, cutaneous and constitutional manifestations of secondary syphilis. Symptoms: fever, malaise, weight loss, skin rash, and usually it's symmetrical and generalized. Alopecia can be seen, condyloma latum, lymphadenopathy, multiple mucous patches covered by grayish-white pseudomembrane and surrounded by erythema, uh, ocular involvement in different types of iritis, optic neuritis, uveitis, um, arthritis and periostitis, hepatitis, glomerulonephritis, and different neurological involvement like headache, meningitis, cranial nerve paralysis, and cerebrovascular accident. So the next slide, you can see that macular, papular, and scaly lesions on the plantar area, and that is common area for secondary uh, syphilitic rash. Characteristic anatomical locations are the arms, palms, flanks, and soles. Occasionally, about 5 to 6% of patients may develop patchy hair loss of the beard, eyebrows, and scalp locations of alopecia, and I'll show you a picture with alopecia. Secondary syphilis is clinically the least difficult to diagnose, although in some cases the clinical manifestations, especially the macular rash, can be confused with a variety of skin diseases. Eczema, psoriasis, drug eruptions, pityriasis, lichen planus, and syndrome with the skin rash plus reactive arthritis, urethritis, and conjunctivitis can be mimicked by syphilis. In HIV infection, things can be even more complicated considering that secondary syphilis may show totally unexpected features. And let's see that features, and we can see the skin lesions of the neck, and you can see that it can be easily misdiagnosed with other, for example, even with folliculitis. The same. Mucous patches or erosions or even ulcers in the oral cavity. So, by visual examination, it is impossible to diagnose, but we can see that the situation is severe and this patient should be evaluated thoroughly, and the doctor or nurse should be protected as well. So the lesions of the oral cavity, and we can see some non-specific rash in the oral cavity, and it can be misdiagnosed, for example, with angina or simple or virus pharyngitis and laryngitis. Latent syphilis. Uh, After the secondary stage, there is a latent period during which the patient doesn't show any clinical signs. Um, in this phase, the diagnosis of syphilis can be made only through a serological test. So, once more, latent syphilis, there is no any clinical signs of infection or manifestation of infection. And the next stage, that is tertiary syphilis or late syphilis, develops in the one-third of untreated patients and characterized by long-term complications. Late syphilis is also called gumatose syphilis with gumas that involves the skin, CNS, liver, spleen, bones, and other organs. Gumars are granulomatose-like lesions that are indolent and can range in a size from tiny deposits to large masses. Skin manifestations may also range from superficial tumefacial lesions to a large granulomatous mass, which can be subjective to ulceration. Cardiovascular syphilis is today very rare and mainly represented by ascending arthritis. Neurosyphilis is caused by focal syphilitic endarthritis in the blood vessels of the brain and spinal cord tissues. Clinical forms such as meningovascular syphilis and parenchymal neurosyphilis today are very rare due to the use of antibiotic treatment. And in this slide, you can see patients with GUMS or gumatose syphilis, and you can see that that is very difficult to misdiagnose it or to do mistake with some other specific ulcers, because you can understand that the severity of the process and locations can be quite different, but previous stages of invasive process of Treponema pallidum should be found out from the patient anamnesis. As I promised, our mouse is an alopecia, so it can be easily mistaken with some other types of diseases. And let's look at this next slide. Silver stain or syphilis showing the corkscrew-shaped treponemas. And these dark lines, these are treponemas pallidum, which are the main or the only cause of syphilis. The best way to identify Treponema pallidum from primary or secondary lesions are the dark field illumination that show the typical motile spirochetes and direct immunofluorescence, a method that uses a fluorescein labeled anti-treponem serum. Using these techniques, it is possible to make the correct diagnosis in almost 10% of cases. And this percentage of untreated primary syphilis, syphilitic chancre. With the exception of the macular lesions, all cutaneous and mucous membrane lesions of secondary syphilis contain treponems. Thus, material obtained from an eroded moist lesion will almost always yield positive results. Nevertheless, limitation can be availability of a dark field microscope and of trained, experienced microscopist. Success is dependent on factors such as too little or too much fluid on a slide, thickness of the smear, slide and cover slip, presence of refractive elements in the spectrum. The test lacks reliability in case of oral lesions because saprophytic trypanomes that cannot be differentiated from Trypanemma pallidum are common in the oral cavity. For dark field examination, the surface of the lesion should be gently cleaned with sterile gauze soaking in 0.9% sterile saline, avoiding bleeding, as blood cells may masquerade the trypanomes. The best result is obtained using the serous exudate that accumulates on the surface after squeezing the base of the lesion. The exudate is mixed with 1 or 2 drops of saline on a glass slide and covered with a plastic cover slip, and then is examined under a dark field microscope. New specific and sensitive methods that employ reserve transcriptase of PCR have been recently developed in order to detect very low numbers of spearheads in clinical samples. Although these methods are not standardized, they have been found to be highly sensitive because able to detect as low as 1 to 10 organisms per specimen with high specificity. However, these methods have not yet reached the stage of widespread clinical application. The serological laboratory tests that are used diagnostically are referred to as a serological or serologic tests for syphilis. These tests fall into two categories: non-trypanemal tests for screening and trypanemal tests for the confirmation. The non-trypanemal tests measuring both immunoglobulin G and immunoglobulin M, antiphospholipid antibodies formed by the host in response to lipidal material released by damaged host cell early in infection, and lipid form the cell surface of the trypanem itself. Instead, trypanemal tests use Trypanemma pallidum or its components as antigen. Despite their limitations and the complexity of interpretation, serological tests play a pivotal role in diagnosis and follow up the syphilis. The non-specific non-trypanemal reagent antibodies tests are inexpensive, rapid, and convenient for screening large number of sera, and are also quite helpful as identification of the disease activity. Benzathine penicillin G or aqueous procaine penicillin G remains the drug of choice for all forms of syphilis. A concentration of penicillin about 0.018 milligrams on liter is considered trypanimicidal. However, serum concentration equivalent to the maximally effective in vitro level, 0.36 milligram liter, is recommended for at least 7 to 10 days in early syphilis and longer in the late stage. This drug is very effective in early syphilis and less effective in the late stages. The principal contraindication is hypersensitivity to penicillins. So, for syphilis, that was all information, and let's move on. Oral manifestations of HIV infection. Oral manifestations are the earliest indicators of HIV infection and can predict the progression of HIV or AIDS. Oral lesions occur in up to 50% of HIV infected patients and in up to 80% of AIDS patients. Since oral lesions are considered the first clinical features of HIV infection, as well as highly predictive markers of immunosuppression, they can be useful for early testing, diagnosis, and treatment of this type of infection and patients with this infection. The introduction of antiretroviral therapy allowed a significant decrease in appearance of opportunistic infections together with a decrease in mortality and an increase of survival and quality of the life in HIV infected patients. So let's look on this slide and we can see the classification of oral lesions in HIV patients. And the first group is on the slide. They are lesions strongly associated with HIV infections, and they are candidiasis, pseudomembranous candidiasis, erythematous candidiasis, angular cheilitis, hairy leukoplakia, Kaposi sarcoma, non-Hodgkin's lymphoma, periodontal disease, linear gingival erythema, necrotizing or ulcerative gingivitis, and periodontitis. And we'll discuss mostly all of them. The second group is lesions less commonly associated with HIV infection, and the different types of infections of inflammations in the oral and maxillofacial region, bacterial infections, Mycobacterium in vitro cellular, Mycobacterium tuberculosis, melanotic hyperpigmentation, necrotic or ulcerative stomatitis, salivary gland diseases, xerostomia, unilateral or bilateral swelling of the major salivary glands, thrombocytopenic purpura, and ulcerations. And the next slide shows us the continuity of the second group lesions. They are viral infections. So viral infections are the common for patients with HIV. Herpes simplex virus, human papilloma virus, candyloma virus, the same, focal epithelial hyperplasia, verruca vulgaris as a part of verrucosis, leukoplakia, varicella zoster, and herpes zoster. Oral candidiasis is the most common oral lesions in HIV or AIDS infected patients with a wide prevalence range starting from 70% up to 75%. Its most frequent culprit agents in Candida albicans, although there are other related species such as Candida glabrata, Candida Tropicialis cruzi, and others. The risk factors predisposing oral thrush development are the CD4 T lymphocyte count. There are three frequently observed forms of oral candidiasis, and they are pseudomembranosal candidiasis, erythematous candidiasis, and angular cheilitis. Oral thrush lesions are composed with white creamy plaques, which are the soft or granular gelatin-like patches that can be scraped off, unveiling an underlying erythematous area which is ulcerated, eroded, and commonly painful surface. These patches are composed of hyperkeratin waste, inflammatory cells, epithelial cells, bacteria, and fibrin. Oral thrush lesions can develop anywhere along the mucosal membrane, and however, the most common sites associated with this condition are the mucosal folding, the oropharyngeal cavity, and the lateral borders of the tongue's dorsal surface. And I showed it for you on the slide. Erythematous candidiasis appears as a red lesions commonly located on the palate, dorsum of the tongue, and the buccal mucosa. And in this slide, in this picture, we can see pseudomembranosus candidiasis and erythematous candidiasis with high, hyperemet or reddened parts of the palate. The lesions of erythematous candidiasis or pseudomembranous candidiasis tend to be symptomatic with patients complaining of burning mouths and change of taste, most frequently while eating salty or spicy foods or drinking acidic beverages. And that is understandable because erosions presents. The next slide or the next manifestation, that is tongue xerostomia or oral xerostomia and angular cheilitis. As you remember, angular cheilitis is a type of oral candidiasis and usually appears as fissures of or linear ulcerations of the commissures and is frequently associated with a small white unilateral or bilateral patches as well as the presence of intraoral edema. Overall, 20% of cases of this disease are caused by candidas, while 60% of cases are related to mixed Candida albicans and Staphylococcus aureus infection. Some local predisposing factors associated with the candidiasis presentation are narrow vertical oral dimensions as well as aging associated highly scratchable skin. These conditions can lead to a salivary contamination on the skin, triggering the decrease. Angular cheilitis can appear with or without oral candidiasis. Xerostomia may be associated with the salivary gland enlargement, but it's also a common consequence of medications used by this population. Cytomegalovirus has been demonstrated in the salivary gland of xerostomic patients. Symptomatic relief may be provided by salivary stimulants such as sugarless chewing gums or saliva substitutes. Prevention of dental caries in patients with xerostomia is extremely important, and the use of topical fluoride gels and rinses should be encouraged. In addition, management of xerostomia will improve oral comfort, the quality of speech, and use of any prosthesis. Linear gingival erythema. This condition is considered a form of gingivitis which is clinically composed of a 2 or 3 millimeters erythematous stick along the gingival frame. It is commonly accompanied by diffuse red lesions or petechial-like wounds scratched towards the apex of the gums as well as the alveolar mucosal membrane. It is usually appears along the anterior teeth through being capable of the growing towards the molars, although with mucosal bleeding and squeezed dental biofilm. Among the representative features of this injury are clinical insertion loss and the absence of ulcers or pain. Multiple candidas have been associated with triggering these conditions. The next manifestation of HIV infection in oral cavity, that is periodontitis. Periodontitis is characterized by microbial association within a dental biofilm as well as a host-mediated inflammation, which triggers the destruction of tissue supporting the teeth. Its clinical manifestation includes the gum inflammation, bleeding, probe, mucosal membranes, periodontal pouch formation, loss of clinical insertion, plaque, as well as supragingival and subgingival stone formation or tartar formation. In more severe cases, even dental displacement might develop as well as a pathological dental migration. In each HIV positive patients, the dental biofilm usually has a relevant microbial heterogeneity involving unusual bacteria within the oral cavity, such as uh, Pseudomonas aeruginosa, Escherichia coli, among others, as well as diverse Candida species, encompasses Candida albicans, Candida glabrata, Candida krusei, Candida tropicals, and Candida dubliniensis. Oral hairy leukoplakia. This lesion usually presents as asymptomatic white vertical corrugated hair-like projections on the lateral borders of the tongue. It can be bilaterally or unilaterally. It can spread to the dorsum of the tongue and on the ventral aspect of the floor of the mouth, and occasionally on the adjacent buccal mucosa. When seen in these areas, it is smooth and velvety, not hairy-like. Unlike candidiasis, the lesion can be wiped off the mucosal surface and leukoplakia the same. That is impossible to get rid easily of these white lesions, and the treatment can be even surgical. Sarcoma Kaposi or Kaposi sarcoma. This is the most common malignancy encountered in HIV/AIDS patients. Kaposi sarcoma associated herpes virus or human herpes virus 8 is causative agent of endothelial cell derived tumor Kaposi sarcoma. The lesions are commonly seen in homosexual men. The lesions are characterized by reddish, bluish, or purple single or multiple markers or nodules. These are seen on the palate or gingiva and may ulcerate. Gingival involvement may lead to the underlying bone destruction and tooth mobility. 22% of lesions are present intraorally, with 35% of patients presenting with both skin and oral lesions. Biopsy is essential for the definitive diagnosis. It is considered pathognomic of the HIV infection. What does it mean, pathognomic? I hope you understand that is a specific manifestation or clinical feature of some different type of pathology. And for today, that is all. That was a long lecture, but I hope it was understandable and interesting. If you have any questions, we'll discuss them on our classes. Thank you for your attention and bye bye.